Thank you to the organising committee for the invitation. I'm sorry that Professor Osala couldn't be here, but I've been asked to stand in his place. I work at Gilead Sciences, based in the UK, and I will talk mainly about the sofosbuvir results and put that into the context. You've heard much about the other agents that are available today and that really are advancing the care of patients with HCV. Of course, sofosbuvir isn't approved in Europe, US, or indeed anywhere, so these slides are preliminary data and no claims can be made about safety or efficacy of sofosbuvir. So just looking at a similar slide that's been seen before about the wealth of direct-acting antivirals that are coming forward, working at different parts of the hepatitis C virus and hopefully in combination bringing greater degrees of efficacy, potency, a good resistance profile, and being well tolerated by patients, and will be used in a number of different combinations in the future. And sofosbuvir, which I'll talk about, fits in this group here, are the polymerase inhibitors, NS5B. On the next slide, looks at the investigational regimes. Some of these are moving forwards already, but I think the good news is that there's many different molecules targeting many parts of the hepatitis C virus and quite well advanced now into phase 3, as well as some compounds that are working through phase 2. So there's no doubt in the next few years we'll see a great step forward in the management of hepatitis C and hopefully bringing better cure rates forward for patients. So what I'd like to do in the next few minutes is summarise where we are with sofosbuvir. And I'll really take a look at the phase 3 studies that have recently been completed and presented. And part of the profile of sofosbuvir has already been mentioned this morning. It's a polymerase inhibitor. It's very potent, pan-genotypic polymerase inhibitor with activity across all genotypes 1 to 6. The barrier to resistance is high, and I'll show you some summary data on that. It's taken as a once-daily oral tablet. And the pharmacology profile is favourable. There's no food effect and no significant drug interactions. I don't have time to show that data to you today. And it is safe and well tolerated. We now have more than 2,000 patients exposed in clinical studies. We're looking for safety signals. We've seen no specific safety signals so far, but of course it's very important that we continue to look for those. So if I look at the 4 phase 3 studies listed here, Neutrino and Fission were both in naive populations. The Neutrino study in genotypes 1, 4, 5 and 6, and Fission in genotype 2 and 3. And then the Fusion and Positron studies were in treatment-experienced patients, 2 different groups of experienced patients. Those had been treated and failed in the Fusion study, and those patients who were for some reason either unable to or unwilling to take interferon or ribavirin in the positron study. And the total number of patients there, just over 1,300. And we were very keen to try and recruit a substantial number of patients with cirrhosis. And you see that on average we had about 20% of our patients in these studies with cirrhosis. So we could start to look at any differential effect in those patients with cirrhosis and those patients who did not have cirrhosis. This is just another way of looking at the trial program, looking at the duration of therapy. Most studies had a 12-week regime of treatment. The comparator arm in the Fission study of 24 weeks of PEG and ribavirin, and we also investigated 16 weeks in the Fusion study. But fairly simple regimens, mostly targeting that 12 weeks of therapy, no escalation of therapy dose, and no run-in period. So fairly simple and straightforward dosing. And the SVR12 is the primary endpoint in all of those studies, but all patients then enter a long-term follow-up phase to ensure that the SVR24, and indeed 3 years after the end of therapy, that you have a consistent cure for these patients. All of these studies, we're very pleased to say, were published at the time of the EASL conference, so they're all presented at EASL, but also were published in 2 papers in the New England Journal. And those 2 papers were in those 2 groups of treatment-naive patients and those patients who are either experienced or were unable to receive interferon. Those are published online, and they also have very full supplements of about 50-odd pages of supplement behind each one with much more detail on the various subgroups and sub-analyses that were conducted. So let's start with neutrino, genotypes 1, 4, 5 and 6. This was a single-arm study, so we used a historical control rate expected of 60% of sustained virological response for peg-riba plus a PI. And we dosed with 12 weeks of sofosbuvir, 400 milligrams, peg interferon and ribavirin. The SVR12 was the primary endpoint. We targeted 20% enrollment with cirrhosis. There was no upper limit on age or BMI. Patients were allowed to be on methadone. Platelet cap was down to 90 and neutrophils are shown there. So looking at the primary endpoint on treatment, we saw a very rapid virological response, more than 90% of the patients virus negative at 2 weeks, and pretty much everyone by week 4 and at the end of therapy. And then the sustained virological response was 90%. 12 weeks after the end of therapy. And as you can imagine, that was statistically significant over that historical control of 60% and established superiority. Just looking at some more data there, as you can see from the graphs, all of the virological failures were relapses after the end of therapy. So during therapy, all patients who went negative stayed negative. And we also looked by deep sequencing for resistance. The mutant, the signature mutant mentioned earlier, the S282T, was not detected at all. If we look at now a breakdown by genotype, the great majority of patients were, of course, genotype 1, and there was no difference between 1A and 1B in response rate. Genotype 4, 28 patients, so a reasonable number with a 96% response rate, and in a few patients on genotype 5 and 6 all achieved an SVR. If you look now by cirrhosis, probably best to look on the far right-hand side of the slide, the SVR. So 92% in non-cirrhotics and 80% SVR in those patients with cirrhotics. So a 12-week regimen achieving an 80% SVR in cirrhotics. Just one slide summarizing safety shown here. And the safety was really consistent with the safety you'd expect to see on peg-ribavirin. There were no additive effects that we detected. The most common adverse events are listed here. And we thought the rate of discontinuation was quite low at 1.5%, just 5 patients. And we think that's a result of the patients being able to tolerate a 12-week regimen of interferon ribavirin, knowing the end of that therapy was coming, and they didn't need to go for a prolonged period. So quite a low discontinuation rate. So the summary, 90% SVR with an 80% SVR in those patients with cirrhosis, a high response rate in that smaller number of genotype 4, 5 and 6 patients, relapse accounting for virological failure with no resistance, and a good tolerability profile. Moving on to the second study in naive patients, this is the fission study, genotype 2, 3 patients. And here we compared standard of care, so PEG plus ribavirin for 24 weeks, to sofosbuvir ribavirin for 12 weeks of fixed therapy. The primary endpoint again was SVR12. We pre-specified a 15% non-inferiority margin. And again, we expanded the inclusion criteria, no age or BMI limit. Methadone or opiate substitution was allowed, and this time the platelet threshold a little bit lower at 75, and we also targeted cirrhotic patients to be included. This is the demographics, if you will, of the study. Nothing so surprising here. You can see genotype 3 accounted for most patients, just over 70%, and the cirrhosis was at that target of 20%. So a fairly good population of 2-3 patients to study. If we go to the primary endpoint here, so if you look through therapy, the blue bars are the sofosbuvir bars. Again, you see a very rapid viral response, 92% of patients negative at week 2, a few more patients at week 4. The interferon ribavirin is what we're more used to, is a gradual response rate going up to, as you see there, gradually increasing over therapy. If you look at the SVR rate, SVR 12 weeks after the end of therapy, clearly non-inferiority was established, both regimens producing 67% SVR. Again, relapse accounted for the virological failures. There was one patient who was non-compliant, who did break through, but was not on therapy after a few weeks. Again, by deep sequencing, we looked for the 282T and did not find any resistance in those relapses. Just going to the next level of detail, for genotype 2, remember this is a genotype 2 and genotype 3 study, very high level of efficacy for genotype 2. There's non-serotics and serotics. Non-serotics on the left, 98% for sofosbuvir, 82% for peg-riba, and then looking at cirrhosis, 91% for the sofosbuvir regime, very high response rate, 62% for the peg-riba, but very wide confidence interval on that result. Genotype 3 results, slightly different. This is clearly a harder to treat genotype, both with peg-riba, and I think we were aware of that, but also with sofosbuvir. So the non-serotics, 61% versus 71%, not statistically different. But if you look at the serotics, the response rates are essentially equivalent, or non-inferior, 34% for sofosbuvir, and 30% for 24 weeks of peg-riba. So looking at the safety again, safety here is really, I think, the safety of ribavirin. You can see on the right-hand side the peg-riba safety. The discontinuation rate was very low on sofosbuvir ribavirin, just 3 patients versus a more usual 11% that we're used to seeing with peg-riba. And nothing remarkable in the rest of the safety results. So the summary of sofosbuvir ribavirin, it provided a simple, well-tolerated regimen for 12 weeks for patients with genotype 2-3, was non-inferior to peg-ribavirin for 24 weeks. The genotype 2 response was very high, and the response for genotype 3 was lower, and that's something we'll investigate further. But the overall tolerability was good. And we're looking more at new strategies for genotype 3, and I'll talk more about that towards the end. Moving on now, the last 2 studies, if you remember, these are in experienced patients. So the fusion study, people who've been treated before and either had relapsed or hadn't responded, comparing 2 regimens of sofosbuvir and ribavirin, 12 weeks versus 16 weeks. Again, the same primary endpoint and very similar inclusion criteria. If you look at the demographics here, you see similar high level of genotype 3, about 60% in this study, and a higher percentage of cirrhosis, 35%. So these patients are advancing a little bit further in their disease. This is the on-treatment response of all patients. So again, very rapid early treatment response, 81% and 87%. For the 16-week arm, and getting to the end of treatment, everyone has achieved a virological response. If you look at the SVR, 12 weeks after the end of therapy, there appears to be a numerical difference there between 12 weeks and 16 weeks in the response rate. 12 weeks response in these previous failing patients, 50%, and 16 weeks, 73%. The primary endpoint was met, comparing to a historical control of 25%. So although retreatment of these patients isn't licensed, if you do retreat patients who failed, again with interferon ribavirin, you will achieve somewhere around 25% response. We compared to that historical response, and these numbers are clearly non-inferior to that. And again, no resistance detected, and relapse accounted for all virological failures. We'll now compare genotype 2 and 3. It's quite interesting. Genotype 2, again, having very impressive and high response rates, 96 and 100% in the non-serotics, and 60 and 70% in the serotics, so 78% for that 16-week treatment group. If you look now at genotype 3, for non-cirrhosis, the longer treatment duration of 16 weeks gives you 63% response. And remember, this is a group where historically you would achieve a low response rate for retreatment with interferon ribavirin. And in serotics, 19% if you treat with 12 weeks, but 61% if you treat with 16 weeks. So there's clearly an advantage of going those extra 4 weeks in patients with cirrhosis and genotype 3, achieving a 61% response rate. So a summary of this study, high SVR in those patients with genotype 2, both with 12 and 16 weeks, and I think on those genotype 3 patients it's fair to say that the 16 weeks really did add a clinically important incremental benefit. Again, relapse accounting for failure and no resistance was seen, and the tolerability was good. There was a low rate of discontinuation due to AEs. So moving on to the final study, which is a positron study. And this is in patients, and I'll show you the breakdown in a minute, who are either ineligible for interferon, had tried interferon and had to stop very quickly into their course because of intolerance, or having had interferon therapy explained to them by their physicians and documented this, they were clearly unwilling to take on the course of therapy. So again, genotype 2 and 3 patients, a fairly simple study design, 12 weeks, sofosbuvir ribavirin versus placebo, and the comparison is the SVR at 12 weeks. These are the demographics. If you look at genotype 2, it's about 50% this time. If you look at cirrhosis, is just under 20%, 15 and 18%. And then in the bottom you can see the break-up of those patients. So about half were unwilling to embark on interferon therapy. About another 40% or so were unwilling, usually for psychiatric disease, autoimmune disease, conditions such as that. And a small number of patients had tried and had to abort interferon therapy early into a previous course. So if we look at the on-treatment response, again, rapid on-treatment response, getting to 100% at week 12 of therapy. And you look at the SVR 12, 78%, and 0%, of course, on the placebo group. Those placebo patients then went on to a retreatment study, so they did receive the benefits of therapy. So the primary endpoint was met of superiority, and again, no relapse, relapse accounted for failures, and no resistance mutations seen. If we look by genotype 2 and 3, again you see a differential, 93% for genotype 2, 61% for genotype 3. And if you look at the safety here, nothing remarkable, a low discontinuation rate, essentially the same on the active and the placebo group, and nothing else particularly to comment on the safety. We didn't see any adverse events which we thought were different from previous ribavirin. So summary of positron, 12 weeks of therapy, achieved a high response rate in those patients who are unable to embark on therapy for a number of different reasons. So these patients would only get that 0% response rate offered by placebo. I didn't show all the data, but a high response in serotics versus non-serotics, and again a lower response in those genotype 3, but again these patients could otherwise not have been treated. Again, no resistance, and the safety was very satisfactory. So looking across the programs, the discontinuation rate was quite low. You remember I mentioned the 11% number for PEG plus RIBA, which we're all familiar with, but generally a low response rate for those groups without, both without interferon or even the group with interferon, the 1.5% when it's only a short duration of therapy. And again, no additional adverse events over the profile you'd expect to see of either PEG or ribavirin. So just the last couple of slides now, the ongoing strategies for genotype 3, because there is still a question there. We have a number of studies. We've got a valence study recruiting across Europe where we're looking at 24 weeks of therapy. The Lone Star 2 study has already been mentioned, where we add sofosbuvir to PEG interferon and ribavirin for genotype 3. The Electron study and another 2A study are looking at newer antivirals. Ladipasvir has already been mentioned, and also 5816. So we've got a number of different approaches. We think over the next 6 to 12 months we'll have much more in the way of answers for genotype 3. And also we have other programs running at the moment, currently recruiting. We have pre- and post-transplant studies. We have a study in decompensated patients. We have co-infection studies running, and of course we're doing global development. We have studies across Asia. We've just started our study in Russia and are starting programs in India. So a very active program to continue to investigate. We believe sofosbuvir could potentially bring some real therapeutic options forward for physicians, but importantly also for your patients. So I'd like to finish there. I've left the name of Andrei Polyakov, my colleague here who runs our Russian medical group, but I thank you for your attention.